Okay, good afternoon everyone. So we'll be learning about retropharyngeal abscess. So let's talk from the slides. Let's talk certain points about retropharyngeal abscess, and then we'll move on to the different slides. Okay. So retropharyngeal abscess is actually it is of two types. It can be either acute or it can be either chronic. Okay. So acute retropharyngeal abscess is more common to children. It is more common to children. Now why? Because children are much more susceptible for adenoid or tonsillar infection. Okay, so any adenoid or tonsillar infection which can actually seed through the lymphatic system. It can seed through the lymphatic system and go towards the lymph nodes, and in the lymph nodes it actually involves the lymph nodes of Rouvier. Okay, nodes of Rouvier, and this nodes of Rouvier, the nodes of Rouvier is actually present in the space of Gillette. So what is the space of Gillette and what is this nodes of Rouvier? Space of Gillette is actually a space, okay, behind in at your retropharyngeal area, and nodes of Rouvier is the nodes that is present there. Okay, and this nodes will actually be infected. Okay, and this nodes is infected secondary to adenoid or tonsillar infections. Are you getting this now? Okay, very good. Now let's talk about the chronic type. So why is there a chronic retropharyngeal abscess? It's all because of tuberculosis. Okay, so tuberculosis is very much responsible for chronic retropharyngeal abscess, and whenever we talk about acute retropharyngeal abscess in adults, the major reason behind it being fish bone injury, chicken bone injury, or it can be an endoscopic, certain, like whenever you go for an ET tube intubation, you might actually land up injuring the retropharyngeal space. Okay, so this is all about the etiology of retropharyngeal space. Now let's talk about different causes of retropharyngeal space. So any cause that can actually involve the adenoids and tonsils, that can be either Streptococcus pneumoniae, Haemophilus influenza. Okay, so these are the different organisms. Plus there are different more. We'll talk about this in the upcoming slides. So how will the patient present of retropharyngeal space? The patient of retropharyngeal space will present with dysphagia, will present with odynophagia, will present with drooling of saliva. He will present with, of course, he might have sort of dyspnea. Okay, kind of difficulty in breathing. And of course you need to understand a very important aspect, that whenever you have a retropharyngeal abscess, there is a unilateral midline bulging. Suppose this is your bulge of retropharyngeal abscess like this. Okay, if it's a total bulge like this, okay, involving all the areas of your posterior pharyngeal wall, then this is actually the bulge of your prevertebral abscess. So I will show you from this diagram. See, so if there is an abscess in the prevertebral lesion, the bulge will be like this, right? So all the layer will be bulged like this. But if there is an abscess in the retropharyngeal area, so this is your retropharyngeal area, isn't it? So this is your retropharyngeal area, this one. So if there is any infection over here, there will be paramedian bulge. Okay, medially there is a midline raphe, isn't it? So you can see here in this diagram that this is a midline raphe. So this prevents the whole a lot of bulge. So the best investigation to differentiate this one is actually CT scan. Okay, CT scan can actually give a better view of what kind of retropharyngeal abscess is it, and what is the seeding of this abscess, because retropharyngeal abscess can later land up into parapharyngeal abscess. So you can see here the retropharyngeal space is actually well connected to this parapharyngeal compartment, isn't it? So it can travel to the parapharyngeal space, leading to parapharyngeal abscess. And retropharyngeal abscess may also later, when it becomes parapharyngeal abscess, can push the tonsil middle, and then tonsil might actually be shifted towards the midline, isn't it? Sometimes it's also written that in retropharyngeal abscess you can see hot potato voice, but whenever we talk about hot potato voice, it's more common to peritonsillar abscess. Okay, peritonsillar abscess. But in some areas it's also written that hot potato voice is one of the feature of retropharyngeal abscess. So just don't restrict yourselves to hot potato voice being peripharyngeal abscess. Okay, peritonsillar abscess. So let's talk about retropharyngeal abscess. It's an acute and chronic, as I already told you. Chronic is because of TB, acute is because of the infection of the node of Rouvier. It's more common to 3 to 5 years because of the infection of the adenoid and the tonsils, more commonly being the adenoid. So you can see here suppression of the retropharyngeal lymph nodes. I already told you that there is a lymph nodes over here. This is known as nodes of Rouvier. Okay, and this is also known as space of Gillette. Okay, you can just look here. See, nodes of Rouvier, penetrating injury from the posterior pharyngeal wall by fish bone or vertebral fractures. Okay, It can be an endoscopic trauma. As I already told you, whenever there is an ET tube intubation and there is an endoscopic trauma, it can actually lead to retropharyngeal abscess. It can actually come from acute mastocytitis post tracking down under the petrous part of the bone. Okay. Now, whenever we talk about the symptoms, of course, we need to understand that all the upper respiratory tract infection, dysphagia, odorophagia, difficulty in breathing, hot potato voice. Okay. Neck stiffness. Hot potato voice may also be seen in the retropharyngeal abscess, or it might be seen in the peritonsillar abscess. So just rule out these conditions. Just don't restrict yourself to peritonsillar abscess. Now, why neck stiffness? So you can see that retropharyngeal abscess is near to the vertebrae, isn't it? So the patient might present with torticollis. Okay. So torticollis is actually the deviation of the neck, right? So over here, what you can see is, you can see that the posterior pharyngeal wall bulge on the left side. You can see it clearly in this diagram. Not that much clear, but if you can see here, see, this is a torticollis like case also. Okay, posterior pharyngeal wall. Okay, this one is slight. I think this bulge is slight appreciated than this one. See the bulge over here and see over here. So I think this is slightly well appreciated than that diagram. Now this is very important. Okay, so before I go to this slide, I will go to this one. So see here. So retropharyngeal abscess, whether or not this is a retropharyngeal abscess, what has happened to the abscess, you need to see this soft tissue shadow. Okay, so just look into this soft tissue shadow. So if you look into this soft tissue shadow, you need to remember 7, 7, 14, 7, 21. So 7, 14, 21. Remember with this mnemonic. This is C2. Okay, C2. At the level of C2, it is more than 7 mm. At the level of C6 and C6, 14 mm in children and 22 mm in the case of adults. Okay, so I told you 7, 14, 21, all the multiple of 7 you can remember in this way. And you can also see certain air bubbles, okay, at this particular area, air bubbles, and the size of the soft tissue is actually increased the size of the vertebrae. It's actually twice the size of the vertebrae. So you can see here, presence of air fluid level, straightening of the cervical spine, okay, spasm of the prevertebral muscles, and certain air fluid level may be seen. Okay, now this was about the X-ray of retropharyngeal abscess. Now let's come to the treatment of retropharyngeal abscess. Okay, so the treatment of retropharyngeal abscess is, you will give ceftriaxone and metronidazole. You want to cover both aerobic as well as anaerobic coverage. Okay, and incision and drainage is a must. Why is incision and drainage must? So see, there's no use of anesthesia. The patient lies under the table. Suppose this is your bed. Okay, the patient lies over here. Okay, his head is hanging down, and then I just go and give an incision at this particular area to just drain out all the retropharyngeal abscess. Okay, so supine with head hanging low from the table, vertical or horizontal incision on the fluctuant area, incision plus immediate suction of the pus, because we don't want this suction to go into the trachea and lead to aspiration pneumonia, isn't it? And then we can also go for tracheostomy. So you need to remember this in a serial manner. Okay, IV